Okay, very good evening to all of you. I have been given the topic of fortune lies in the bottom of the pyramid. My worthy opponent has spoken just now, Dr. Himanshu, and he showed the picture of a plane. And the debate is here whether a business class is a must or not. The debate is whether you actually need an iPhone 11 or not, iPhone for a cell phone. Now, Vision 2020 was one of the questions which we used to get in our community ophthalmology question. And it turns out that we didn't have a vision of 2020 at all of what was going to happen in 2020. We have all fallen on our face in these COVID times, and propagating premium IOLs is going to make matters worse as regards reduction in the incidence of preventable blindness. We took the Hippocratic oath, serve the humanity. But if we are going to propagate premium IOLs, I'm not sure if how much of the humanity we can serve. There is one thing in COVID times that it has taught us. We have to respect what is required most and not what is a luxury. Cataract means different to different people. For some, it is fine print is important. For some, view of the field of in the village is good enough. Now, India is the largest consumer of IOLs in the world, and the premium IOLs are a fraction of it. Population of nearly 1.5 billion now, and we have to think about everybody. We cannot think about a select few. And the number of cataract surgeons that we have are limited to less than about 10,000. India is home to 1/3 of the world's blind population, and how can you talk only about premium IOLs and the elite? One of the statements that Sir said in the middle was, money put to one side. Money cannot be put to one side because it is one of the most important things. What Dr. Srinivas is saying, Sir is treating the who's who in Maharashtra, but more than 50% of the population of Maharashtra lives in rural area with agriculture as their main occupation. So monofocal is the way to go for India. The cost of SICS is about $20, whereas if you are going to do flax in a clinic with like Dr. Himanshu's, it's anywhere between more than $500. So premium IOLs are a luxury for privileged few. What you see on the top is what India is, and they cannot afford the trifocal IOL that you see below. Now, we cannot just go running behind and copy what they are doing in the West. We have to have our own systems of reducing the incidence of blindness. Indeed, fortune lies at the base of the pyramid. My submission is not against the science of the premium IOLs, which Sir was saying. But its implementation in the country of 1.5 billion people. Progress is not about science, is all about science, but it should not have a road roller effect on our common masses. Let's talk about the turnover of Arvind Eye Hospital, Disha Eye Hospital. Dr. Debashish Bhattacharya is sitting in the panel. Dr. Sitapur Eye Hospital, Chitrakoot. I'll just tell you, leave alone how much you are making money in the premium IOL sector. Disha Eye Hospital has invested in the past few years 100 crores in West Bengal, and they have a module for it. Arvind Eye Hospital, it reaches out to all reaches out and serves to all those who are in need. Arvind Eye Care started as an 11-bedded eye hospital, and now they have seen over 40 million patients. Unbelievable. And what they do not depend on donors. Their net profit, and this is from a few years back, was $8 million. Forget about changing it to rupees. I will lose count, but this was in 2010. I think it must be $15 million now. Over and above all that, when you have to put premium IOLs, you have to put in manpower, you have to put counselors and counseling for all these things, and then you have to deliver that. That burden is on the patient, and over and above that, the surgeon also has a lot of burden in buying Pentacam, IOL Master 700, and for the rest of his life, he will keep returning all the EMIs in the bank.
60
After
seconds.
all that you have done, you still have to tell the patient that there will be halos, glare, there may be there may be contrast decrease, so on and so forth. It is much more difficult to manage refractive surprise in patients with premium IOLs as their expectations are very high. And then you have a list of things where you cannot put these premium IOLs with those who have ocular surface disease, keratoconus, monofocal IOLs, those who have low endothelial cell count, macular disease, diabetic retinopathy, patients who have unrealistic expectations, and those who have issues with the weak zonules, whose angle kappa is more in pediatric patients, in small pupils, in patients who have had refractive surgery, and those are the patients in future who are going to come more to our clinics. And just a food for thought, in all those young patients who we are putting the multifocal and bifocals, after 30 to 40 years, all these patients God forbid, if they have ARMD or corneal pathologies, how will this trifocal and multifocal act is something that we should be thinking about, or will it be the monofocal patients who will fare better? Thank you so much for your patience here.